Love this podcast? Support it and sponsor today. Simply head to ozcastnetwork.com for details.
Hello everybody, welcome to Talking Tendons. My name is Peter Meliaris. I am the host of this show whose main purpose and goal is to disseminate tendinopathy knowledge to the broader clinical and non-clinical world. So here we go. The first time I'd said that, sounds pretty cool, doesn't it? Maybe that can become a little bit of a slogan, disseminating knowledge to the clinical and non-clinical world. I'll have a think about it. So today I'm going to talk about high-volume injections. High-volume injection is a relatively new injection for Achilles and patella tendinopathy, but it is used in other areas as well. Some people call it a strip, and it was originated by a doctor who works in London. His name is Dr. Otto Chan, and I had the immense pleasure of working with Otto for probably 2 or 3 years when I was living and working in London from 2006 to 2011. So towards the end of that time, I worked with Otto. Otto is the inventor of the high-volume injection. The way that he puts it, he invented the injection so that he can devise some sort of mechanical treatment to strip or to mechanically distend and separate the vessels that grow into the deep side of the Achilles tendon from Kager's fat pad. That was the original rationale. Because remember, in those days, the thinking was, which still is partly true and partly the case, is that the vessels that grow in with nerves from the deep fat may have some part to play in the pain mechanisms of tendinopathy, with sort of a biochemical response that would ensue from some of those neural structures. Potentially that is still the case, and that's partly explaining the pain mechanisms in Achilles tendinopathy. We don't know, but that was really the key and the central theory in at that time, and that's when this injection was developed. I would say probably 14-15 years ago. It would be about right. So subsequently, Dr. Otto Chan and his team, which includes Professor Dylan Morrissey and other people at Queen Mary and at the East End. There's lots of people there. Professor Mafuli was there for a while, and lots of others have contributed to trying to develop an evidence base, primarily through case series of their own patients who have had the high volume injection, and a lot of those have been positive. So that's been sort of occurring in the background. I as I said, I had the good fortune to work with that team, and I saw lots of high volume injections and applied the rehab afterwards. We used to do lots of athletes and lots of other folk that were sort of sedentary, non-athletes, pretty much the whole spectrum. And what I saw with my own experience when working in the East End with that group is that the injection seemed to be effective, but we didn't have robust evidence, and that is trials. So then Henning Langberg, who was a collaborator at that time, came over and had a sore Achilles, came over to visit me. Queen Mary had a sore Achilles, ended up having an injection with Otto Chan, liked the injection, and then we thought, let's do a trial. So then one of his students, who's Anders Boesen, the lead author of this first paper, ran the first trial on high-volume injections, and that first trial, so that was published in American Journal of Sports Medicine. I'll link to the notes here. And in that trial, we compared high-volume injection to platelet-rich plasma injection to a sham injection. Now, I should say what the high volume injection involves. It involves 5 syringes of 10 mils of fluid each. 4 of them are saline, so 40 mils of saline, and one of them involves 10 mils of local anesthetic with a little bit of steroid. And that just is a paraphrase, or a direct phrase, I should say, from Otto Chan, because he always used to say there's a little bit of steroid in there, almost sort of cheekily trying to get in the fact that, we've put a bit of steroid, but don't worry, it's just a little bit. Clearly, we don't really know what the long-term effects of steroid are. There are discussions about whether there's detrimental effects long-term, like recurrence, sometimes ruptures. This is all debated. The evidence is not really strong enough to tell us one way or the other, and it really does come down to people's experience. But anyway, so this high volume injection is basically a cocktail of those 3 drugs, and we compared it to platelet-rich plasma, which is people's plasma, blood that's with the plasma concentrated in the normal PRP way, and what we found in this trial with a 6-month follow-up was that there was actually a much better effect of the high volume injection in the short term. So in the first 6 and 3-month follow-ups, the high volume was superior in terms of outcome for things like pain and function when compared to the PRP injection. Then at 6 months, PRP and high volume were both superior to the sham injection. Okay, so this is that was an interesting finding for a number of reasons. First, it showed that high volume works in the short term, and the big question mark there is that just a steroid effect? And second, it also showed that PRP was superior to placebo or sham, and that ours was the first trial to show that. Now, there could be a number of explanations. It could be that it is better. It could be that our sham was not effective enough, and we didn't, unfortunately, ask people if they perceived that they were in the sham group. The sham we used was a few mils, so 1 or 2 mils of saline under the skin, which is a very small amount. So it's potentially true that our sham was not effective enough. The next potential explanation is that the exercise group that we they all had exercise as part of the inclusion into the study. So all 3 groups had exercise. So you can't really say the exercise wasn't effective enough, because they all had exercise and there were group differences. So I don't think that is the right interpretation to explain the group differences, but it's true to say that our outcomes were very poor for visa. We know that visa should change by about 20 points in about 3 months, and our change was more like 10 points, so very, very modest for the exercise-only group, the sham group. So there was something going on with the exercise intervention. It was an eccentric intervention, so perhaps there was very poor adherence, which again we didn't measure robustly. So there are limitations in the trial, and one of the most important ones is the sham and how effective the sham was, because I think something like an injection can have a considerable placebo effect, and if you're not controlling for that, then that can be a problem. The issue, or the interesting part about it is that we saw short-term effects for the high volume in the short term. So the follow-up trial, and this has just been accepted. Anders Boesen is the first author again into the Scandinavian Journal of Medicine, Science and Sport. So it will come out in the next few weeks, and I will link it to the show notes when that happens. In this trial, we took out the steroid from one of the high volume arms, and we compared the high volume minus steroid and the high volume plus steroid. And this was interesting because what we found here is that indeed the short-term effects of the high volume injection disappear once the steroid is removed, and that strongly suggests that the steroid is the key driver of the short-term effects. So then what we are moving towards now is we're moving towards testing high volume versus high volume without steroid versus sham. So this is a trial that that we're about to start via Monash, and we have some money from an Australian government funding source to test those three groups, and we'll test whether the high volume injection, the steroid, or the high volume injection with the steroid or without the steroid or sham, whether there are differences. So the hypothesis is that we will see improvements in pain and function in the high volume groups compared to the sham group. We want to see whether those improvements are maintained at 12 months, particularly for the steroid group where there is question marks about potential recurrence with the steroid. So that's an exciting trial. It's something I'm very excited about, leading that trial over the next few years. We're recruiting just under 200 people for that trial. So I wanted to share that and the two papers. In terms of clinical output from the two papers so far, we still don't know whether the steroid is detrimental in the long term. My view is we do need the trial to test that, and that was one of the main motivations for the trial. Using a stripping injection is without the steroid is likely to be a safer option given the uncertainty about long-term effects. And the reason I'm interested in injections is because classically I am a physiotherapist and I like to provide exercise and get people to better with exercise rather than injections. So injections are not something that I recommend very often at all, but we do have to recognize that two important things. One, many people inject for tendinopathy around the world. So we need to, as scientists and as caring clinicians, have an injection or at least have some sense of developing the evidence base and not just saying, oh, we shouldn't be injecting, there's better things to do. The reality is not everyone improves with exercise. Not everyone improves with exercise. People often go for shortcuts. Now, injections are shortcuts. I don't agree with that. I think that's not a good thing, but people will do it. If there is a shortcut that has an additive effect to rehabilitation, shortcut in inverted commas, if there is an injection that has an additive effect to the rehabilitation process, doesn't set people back like PRP often can, in my opinion, that would be, pretty amazing. It would help a lot of people. It would give them something. It would add to their rehab process and allow them to improve potentially more in a more time-effective way. And I think that would be quite beneficial. So I don't think we've explored. I don't think we can sit back and say injections don't work, PRP doesn't work, steroids dangerous, let's just not do anything. There is potential to provide patients with something that can have an additive effect. And I think there's many questions. That is, what is the long-term safety and recurrence from steroid? Are there additive effects to things like, well, first of all, is there long-term safety and is there long-term benefit from high-volume injections? Are there additive effects to rehabilitation from these injections? You notice I haven't asked any questions about PRP. I'm a little bit less enthusiastic about PRP because with PRP, we know that no studies so far have really been able to, aside from ours, show that it improves over placebo. But the weight of the evidence shows it doesn't work over sham, and I think that's something we do need to consider. And the other issue with PRP is the rationale is really questionable, given that we're trying to mimic a complex healing process with we're trying to mimic a complex healing process with an extremely blunt. Using an extremely blunt method, so i.e. just putting some growth factors in. I don't think that is ever going to lead to healing within a tendon. So I just don't see that as having. I think it breaks down at that sort of basic rationale level. But having said that, I think, as with everything in science, it probably deserves to be on a basic science level tested and seeing if, again, it can have additive effects. But it needs to be tested in a much more robust way than what it has. And I think in a basic science level, before we progress the thinking to humans and just try sort of scattergun approaches of various concoctions that really are so variable, they just don't allow you to conclude anything. So anyway, that is my 17-minute rant about injections. It is something that, even though I love rehab and I have a passion for rehab, I think it's something that, as scientists and as clinicians, we should think about. And as I said earlier, there's masses of people doing injections. So either we should do research and just stop the practice if it's shown to be non-safe or non-effective, or we might find that there's additive effects. So there are potential silver linings to these, avenues. I did want to mention there's a injection seminar that I am hosting via Monash. I'm getting Otto Chan out, Prof. Dylan Morrissey, lots of other speakers like John Orchard and Jane Fitzpatrick and Brooke Coombs and Glenn Whitaker and lots of other people. Dean Samaras. There's going to be lots of people, lots of different thoughts, and it will be very interesting. Lots of debate. We're going to have a couple of the sports docs like Adam Castricum, Peter Larkins will be chairing sessions and emceeing. So it should be a great day with lots of discussion. That's on the 4th of May. I will link. I'll provide an Eventbrite link to this podcast as well. Thank you very much for listening, and I will see you next time.
Love this podcast? Support it and sponsor today. Simply head to AuscastNetwork.com for details.